Hey folks, welcome to the AABIP podcast. This is Samir Abasarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm your host for this episode. Thank you for joining us. Today we'll talk about spray cryotherapy, a relatively newer tool in airway therapeutics. I'm thrilled to have Dr. Otis Rickman join us. Otis is the director of bronchoscopy and interventional pulmonology at Ascension St. Thomas and a professor of medicine at University of Tennessee Health Science Center in Nashville, Tennessee. He's a chair of the CHEST Live Learning Subcommittee and a member at large of the IP section of the CHEST Thoracic Oncology and CHEST Procedures Network. Otis, do you have any relevant conflict of interest to disclose?
Yeah, I think since we're talking about spray cryotherapy, I do consulting and procedural proctoring for Steris, which is the company that currently available spray cryotherapy system in the U.S.
As a reminder, the views expressed on this podcast are those of the speaker in mind and not necessarily endorsed by the AABIP. With the formalities done, let's get started. So managing major central airway disease is an important part of practice for interventional pulmonology. It's truly one of the ways that we make people feel better and breathe better. There are lots of tools that are disposable. The use of the contact cryoprobe is established, but spray cryotherapy is newer and gaining popularity. Let's get the lowdown from our expert. Otis, in a nutshell, what is spray cryotherapy and how long has it been around for?
All right. Well, so is that there's two forms of cryotherapy. So there's a probe with the Joule-Thomson effect and a carbon dioxide or nitrous oxide. Been around for a long time, but sort of limited applications for bigger surface areas, that sort of thing. So spray cryotherapy is a form of cryotherapy where liquid nitrogen is forced through a catheter and onto a surface that's being treated. All of us are very familiar with spray cryotherapy when we go to the dermatologist and something on our arm, a little mole, a little discolored area that needs to be frozen off, and that's typically what for that. So that's spray cryotherapy. Now, in the airways, spray cryotherapy has only been around, at least popular wise, since probably the mid 2000s, 2015. It came on the scene in the 90s, and mostly for Barrett's esophagus. And so it's an interesting story on how it was developed. But there were some enterprising people in Baltimore that said, "Man, we should be able to use this in the airways." And so they tried it out, and lo and behold, they were able to make it work. And then some things needed to get refined over the years, but then it got 510K cleared, and it's been sort of used in the airways virtually over so 2014, 2015.
Great. Sounds like another success story from a tool that was initially or more formally used in the GI space that made its way over to the airway. So compared to its cousin, the good old cryoprobe, any significant advantages that we should know about?
So
We should know about?
I think one of the things that was sort of that I alluded to was that because this is spray cryotherapy, the surface area is bigger. So if you've got an area that you need that is like, let's say, carcinoma in situ, so there's a big carpet of stuff, and you really can't see a pinpoint area to treat. You can treat, about 2 to 3 centimeters of area compared to whatever you get with a probe. 1 point to 2.8 or something like that. And so it can really decrease the amount of time that you spend doing freezing or doing your therapy. The other thing that's different is that cryogenic properties are different than a cryoprobe because this is liquid cryoprobe. Because this liquid nitrogen, it gets colder faster, so you get immediate cell death with nitrogen versus a probe, which is a slower freeze. And so what you get dehydration of this and sort of ice crystal formation through dehydration. that you get with spray cryotherapy.
Okay, so a little bit of wider treatment area and a
So
little
what
bit.
I guess,
Go ahead.
yeah, and then one other thing that I followed up with on that is that spray cryotherapy is not a debulking agent. Most of us use agents. Most of us use the cryotherapy for its cryoadhesion effect. So we
Hmm.
use it. You basically stick two tumors and then we forcibly pull them out. So spray cryotherapy by itself is not to open up an airway, especially critical. So you do something else to it. If it's tumor, you need to excise, or if it's a stenosis or something like that, you need to make it bigger because there'll be some swelling with spray cryotherapy that happen. And these tools are not mutually exclusive. And I'll tell you that you know mostly use them in other um, to uh, so there's nothing sort of vacuum.
Gotcha. So you mentioned the application for carcinoma in situ. What other clinical scenarios do you find this tool useful for?
So if we just sort of take things and we divide them into malignant and benign. If we include the malignant things, so uh, you know carcinoma in situ would be one. If you have even invasive squamous cell carcinoma, something like that, that you got a margin that's positive from a lobe in that, sort of decreasing of the size of a resection. Yeah, I found it to be very useful in that. There's an emerging indication for the larynx and vocal cords, that sort of thing. So some ENTs are starting to explore its use there.
Hmm.
Again, also in sort of this superficial squamous cell carcinoma. Carcinoid tumors are something I find very useful in. And one of the nice things about using it in tumor is that sometimes the carcinoid tumor is not always on the airway basement membrane. Sometimes there's a full thickness penetration, and using spray, you can actually depend on the heat effect to protect you from causing a vascular fistula, and you can penetrate 2 to 3 millimeters with with the file with spray cryotherapy. Um, so benign disease. Papillomatosis is one that I really like to use it for. Again, especially for people with sort of diffuse carpeting of the airways, and
Hmm.
so typically we'll sort of deep those and get it down to a smaller. You can spray a large surface area, very treat a large area very quickly. Um, Benign central waist stenoses, and I say central because there's some safety reasons that you may not want to be doing peripheral stenosis, with spray out there. But so subglottic, tracheal, post intubation, idiopathic. I'd say those are the bulk of the patients that I use this treatment in.
Okay. I'd love to hear your approach for subglottic stenosis. Let's say a patient comes in, let's just call it idiopathic. You have them in your endoscopy room or your OR. Walk us through what you do there.
Sure. So there's several things we do there, and so we've actually, I'll just give I won't go through the paper, but just to point the listeners to a JOB paper that reports on our experience using this for central airways. Our former IP, our current upcoming IP fellow, Kush Rickman, lead author on it, but and it sort of kind of goes through our approach. But I'll tell you what our approach is. For stenosis, I typically do an LMA,
Hmm.
which is sort of evolved over the years. The company initially was very, you do a rigid, or you need to do an endotracheal tube for safety reasons. And as there were some advantages to or suspended laryngoscopy was the other thing we're doing originally, and and then the IGL LMAs. It's this nice big lumen. It sets really on the larynx and fits tightly. And so I started doing these in 2015 through the IGL LMA, and with very good results. And so our IGL LMA, TIVA, Typically, the patient is relaxed. Sometimes we don't. We just do typical anesthetic upper airway. And then once we where the stenosis is, then I use spray cryotherapy in what they call a booking fashion, meaning that I'll spray first,
Hmm.
and it's 5 to 10 seconds on a normal flow setting, something to the airway. And typical practice has been to use an electrocautery knife and make radial incisions into the stenosis at, usually kind of at 0 degrees and 270 degrees, 12 o'clock through 170 degrees, 12 o'clock through 9 o'clock. Just to kind of give an area for my balloon, which I do next to expand. And so that it's not a wild type sort of tear. It'll the airway will dilate, cut lines that were made, and then dilate it up. And as long as sort of tear, sometimes, depending on if the fellow's done it before or not, we'll inject Kenalog or sometimes mitomycin will be topically, but I've never found those to be 100%. Efficacy. The jury's still out for me on those. And then we'll typically finish with another of cryotherapy for 5 to 10 seconds. And then typically back in about 6 weeks, have a look, see if something else needs to be done. And what I found with spray cryotherapy is that, as opposed to many years ago, it is decreasing the need for me to have to commit to for long-term endoscopic management.
That's great. The more durable response our patients can have, the better it is for them, and the better it is for us too. I'm glad we're able to offer this. So, just to recap for our listeners, it sounds like you spray first, cut, dilate, plus minus steroids or other adjuncts such as topical mitomycin, and finish out with the spray. Is that correct?
That's correct. And then I'm very cautious with the final spray because if you have a full thickness sort of rent, you don't want to set just because of the risk of pneumomediastinum or an air embolism. But like the typical of little laceration that you see with dilation, those are okay to spray. But thickness ones you want to spray at the
Gotcha. Good to know. You talked about this a little bit about situations where you don't want to use spray cryotherapy, and you mentioned sticking to major central airways. Any other situations where you would hesitate to use this tool?
Yeah, so there are a couple things. So number one is there's some safety concepts. I think is probably what to get through. So there's a concept of I can call it stay safe, and so the number one complication of this procedure is thorax and pneumomediastinum. So 1 ml of liquid nitrogen expands to 700 milliliters of gas. So if you don't have excellent egress, either out an endotracheal tube, out through an LMA, or out through the rigid bronchoscope, then you're going to get into whenever we use an eye gel and spraying, so we start proximal, we treat a stenosis, so we wouldn't go through a subglottic stenosis and then treat distal tracheal stenosis. So you always want to manage the limits possible proximally like distal. And so if you're using an eye gel, you want to make sure that somebody's watching, and you want that the chest not rising and that the belly is not rising, so that you're not getting insufflation in the stomach. So that's one thing. You want to, if you're using an endotracheal tube, you want to, because most of our therapeutic scopes are 6.2 millimeters. The catheter requires a 2.8 working channel.
Hmm.
And so if you have a 6.2 therapeutic scope, to allow enough gas to come out, you can usually always know that there's going to be enough to allow adequate egress if you have an 8.5 endotracheal tube. And so, there's a chart that's on the system that, kind of will go through your scope size, and the safety features of it, that sort of thing. So So for safety purposes, making sure that you either have a rigid scope in, a adequate purposes, making sure that you either have a rigid scope in, a adequately sized endotracheal tube, uh, and or an eye gel with appropriate precautions on the eye gel. And then you wouldn't want to, so if you can't relieve the proximal stenosis and you don't think you have enough lumen enough to escape, you wouldn't want to do spray cryotherapy in that situation. If you have somebody that's really hypoxemic,
Hmm.
then you're probably not going to want to do spray cryotherapy then either, because this is kind of the opposite of a nitrogen washout, right? So we're actually spraying nitrogen into a gas. It washes oxygen out, and so you can have a pretty profound hypoxemia if the patients have any sort of oxygen requirement at all. So just be cautious with that. It's not an absolute contraindication. And then, I'm always on the watch out, especially when I'm spraying kind of at the carina or in the proximal right or left main, kind of at the carina or in the proximal right or left main stem bronchus for somebody that has, a history of, bradycardia or syncope or vasovagal or something like that. The cold can have a very profound sort of bradycardic response in some people, and so something like that to manage that is a good one. But really, there's not very many absolute contraindications to spray cryotherapy, and so really the only one I can really think of is profound hypoxemia or an inability to have adequate egress of gas.
You bring up some good points, and I find the profound hypoxemia very interesting because in patients that are very hypoxemic, and we're supplementing a lot of FiO2 to help meet their needs. We tend to not use heat-based therapies because the risk of airway fires, and go more towards cold-based contact cryoprobe for debulking. That said, we know that this is not used for debulking, but it's kind of the opposite that we need to keep in mind for these patients who you may consider using spray cryotherapy for. It's good to know. With this tool, any special billing codes you use when you're doing these procedures?
It's the same ablation code, so that you for relief of stenosis. So what is that? 31641. There's not a specific code for it. So it's the relief of stenosis code. I believe that's 31641.
Okay. Is this now your go-to tool for respiratory papillomatosis? Any use of the additional use of the microdebrider? You feel like this does a pretty good job enough by itself?
Yeah. So yeah, if it's a focal papilloma, this by itself can be enough. If it is a really big papilloma, then you want to get this. You want to. So again, papillomas typically have a big, and so vascular lesions are very cryosensitive. But if there's a lot of blood flow, they can actually be protective, meaning that you'll never get it cold enough because of the blood flow that goes through it. So a lot of times in really big papillomas or big tumors, eyelids or big tumors, in your depth of penetration again is only going to be about 2 to 3 millimeters. So I find that with papillomatosis, if you can get the lesion, down, to the airway surface or to the epithelium, to where you have very little bit of a stalk to left, is the most efficacious use of spray cryo. And so I use a microdebrider very often with these, and we'll go through and take all the papillomas down, down to the airway epithelium,
Hmm.
and then come back through and then sort of carpet bomb, so you can spray the entire airway with a few sessions of a 10-second spray, and start distally and pull proximally.
Excellent use of a multimodality approach in that particular instance. So, Otis, time for closing remarks. Anything you feel we left out that's important to discuss about spray cryotherapy?
Yeah, I think that one of the things, we really didn't talk about sort of the pros and cons of it versus hot therapies.
Hmm.
And one of the things about spray cryotherapy that is that's very interesting to me, and I think it's lead advantage, is that healing that happens with cryotherapy. And this doesn't matter. This makes no difference if it's the skin or if it's if it's the airway where it's at. The healing is regenerative rather than reparative. So if you use a laser or you cut something, then you destroy tissue planes, you destroy collagen, elastin, etc. And sometimes the fibroblasts just aren't, as good as the original, and you get sort of scar formation.
Hmm.
And then whenever you get scar formation in the airway, that's also known as stenosis. And so if you have to repeatedly treat somebody over time, then the scar that you're treating is actually getting stronger and more firm because of the act is actually getting stronger and more firm because of the act of your intervention. And so that's where I think cryotherapy comes in, because it doesn't hurt the cartilage, the collagen, the elastin. You don't see these stenoses developing. You can treat circumferentially. We've always talked about not doing heat therapy all the way around scarring. With spray cryotherapy, you can sort of treat with impunity, and you don't have to worry about that scarring.
Otis, this was fantastic. I'm sure our listeners have a lot to gain from listening to this, and we really appreciate your time.
All right. Thank you very much for the invite, Samir. It's great chatting.